Hi guys, and welcome back to my channel. If you are new here, I'm Lani, I'm a first year medical student, and I am covering a range of topics in mind maps. So they can range from diseases, from different physiological concepts or processes in the body, and how everything just fits in together. So if there's any topics or any content that you want me to cover, please drop a comment below or find me on Instagram and DM me over there. So today we're going to be looking at the common causes of acute deterioration of renal function in a patient that already has pre-existing renal disease. So when we look at risk factors, they would include things like your hypertension, diabetes, because we know high glucose is damaging to the nephrons, older age, sepsis, hypovolemia, because we have that lack of perfusion, so it may lead to ischemia of the actual nephrons and the capillaries and the tubules, cardiac surgery, infusion of contrast agents, which is directly toxic to the nephrons, pre-existing chronic kidney disease, cardiac failure, liver failure, recurrent UTIs, and heart disease. So all of these can make a person more vulnerable to actually experience acute kidney injury in the first place. So it's called acute kidney injury because they found that it's on a continuum where 54% of end-stage renal disease patients actually had an episode of AKI in the 2 years preceding their chronic kidney disease or their end-stage renal disease. So what exactly is acute kidney injury? So this usually occurs within 48 hours and it is characterized by an abrupt kidney deterioration. So we can see that in the function, and it is also manifested by an increase in the serum creatinine level with or without reduced urine output. The reason for this is the only way our bodies can excrete creatinine is through the kidneys. So if that starts building up in the serum, we know that there's an issue with excretion. So there has to be an issue with the filtration of the kidneys. So when we look up here, we can see that there's different stages. So we have stage 1, 2, and 3, and they are based on both serum creatinine and urine output. So our serum creatinine, we can see that we start off with, and I'm using micromole per liter because that's the units we use here in Australia. So if we have an increase of 26.52 micromole per liter or greater, or if we have a 1.5 to 2-fold increase from baseline, that would put a person in stage 1, for example. At the same time, we also look at the urine output. So if they have less than 0.5 mils per kilogram per hour of urine output for more than 6 hours, that would be in stage 1 as well. So each of these stages have their own parameters that we would be looking at to decide in which stage this person is of acute kidney injury. So when we look at the pre-existing renal disease, as we come down here, the thing is, it forms, as you'll see, this circular pattern. So it's a chain reaction, and it's just continuous because your pre-existing renal disease predisposes a person to more episodes of acute kidney injury, and an acute kidney injury will basically lead to a person having further renal disease. So this is not an extensive list over here, but it includes like your diabetic kidney disease, your glomerulonephritis, kidney stones, chronic kidney disease, your polycystic kidney disease, and congenital malformations. So all of these are examples of your pre-existing renal disease that could make a person more susceptible to acute or chronic conditions. So as we come down further, your chronic kidney disease may result from disease processes in any of these 3 categories. Okay, so first we need to look at what do we mean by chronic kidney disease, and that is when we have an estimated glomerular filtration rate. Now remember, we talked about the serum creatinine level. So to estimate our glomerular filtration rate, we are using our serum creatinine level, as well as age, gender, and race. At this point in time, they're still looking at refining the formula that we use for that. But at this stage, so your eGFR, if that is less than 60 mils per minute per 1.73 square meters, then for 3 months or more, it is classified as a chronic kidney disease. And it basically also indicates that we have this progressive loss of function, and the ultimate end is going to be the patient will need renal replacement therapy. So when we look at these categories here, we've got pre-renal, which has to do with the actual perfusion of the kidney. So if we have decreased renal perfusion, like we have volume depletion, this will lead to decreased renal perfusion pressure. So there'll be less blood to provide oxygen, and it may put the kidney at risk of becoming ischemic, and we get further damages caused by that. Our main or our most common cause for a pre-renal issue is hypovolemia, and this can happen from diarrhea, vomiting, if a person takes diuretics, osmotic diuresis from poorly controlled diabetes, like your diabetes insipidus, hemorrhage, where there's that sudden loss of blood out of the vascular system, and then traumatic or septic shock, where we have that severe drop in the blood pressure because of all the cytokine releases. So we also have decreased effective blood volume, and this is like in heart failure. So basically, the blood volume is there, but it's not getting circulated, and then in cirrhosis as well, where we have that issue with the decreased effective blood volume. We also have issues with vasoregulation that could influence this perfusion, and this is like medicines such as your NSAIDs, your angiotensin converting enzyme, so your ACE inhibitors, or your angiotensin 2 receptor blockers, your ARBs, and then of course your hypercalcemia. So because this, your, like for example, your hypercalcemia will lead to a lot of vasoconstriction because the smooth muscle cells will continuously contract because of that high calcium that's available to them. All right, so if we come to the post-renal is mostly obstructive, so, and it forms about 5% of the actual CKD cases. So, and it's basically obstructive nephropathy. So this can be urinary tract stones, prostatic hypertrophy, where we have that pressure on the urethra in males. We have retroperitoneal fibrosis, like your intra-abdominal processes that encase the ureters start to have these fibrotic depositions, and it starts to occlude from the outside in the ureters. And then like prostatic and other pelvic malignancy, because we have these growths that shouldn't be there, and they can actually squeeze on the ureters, causing this blockage of the urine, and this build up then that pushes back into the kidneys, and that leads to the actual damage of the nephrons. Then we also have intrinsic renal. So this is where we have pathology of the vessels, the glomeruli, or the tubules interstitium area. So it can be due to acute tubular necrosis, where it can be the result of pre-renal injury. As we were saying, if we have an hypoxic state due to the lack of perfusion, it can lead to the tubular damage, so tubular necrosis, or it can be direct toxicity. So as we said, hypertension, hypovolemia, and hemolysis, rhabdomyolysis, where we have and like, so your myoglobin is actually directly toxic to the to the endothelial cells, or nephrotoxic medicines like your NSAIDs, your lithium and aminoglycosides that we often take. Right, and then we've got your interstitial nephritis, and this is most commonly medicine induced, and there's a long list of medicines, and that is why it's very important that when you prescribe any kind of medication, you need to understand what actually happens at a cellular level to understand the risks of it. Acute glomerulonephritis is another one, and this can be due to small vessel vasculitis. Is one of the causes there. So now we've gone through the three categories, and remember these can be acute onslaughts, or it can be the reasons why we have the CKD in the first place. So it carries weight for both. But now what happens when we have CKD? We know that most of the cases of acute on chronic kidney injury occur in the presence of an infection or other concurrent illness, and this is quite likely that the person would be then prescribed medication, and because the kidney is already not working that well, you put medication in there. As we saw, we have medicine-induced nephritis of the interstitium. We can get issues with vasoregulation. We can even get hypovolemic issues. So that is quite a common underlying thing for this acute on chronic kidney injury. Now, your patients with the chronic kidney disease, they already have altered autoregulation. Now, when we talk about autoregulation of the glomerular blood flow, we talk about the myogenic and the tubular-glomerular feedback mechanisms, which we will cover in a later mind map. But if that's already altered, it means that we either don't have optimal blood flow to the glomerula and to the rest of the the tubules and things, or the pressure might not be regulated enough, so it can lead to damage to the glomerulus, even further due to high blood pressure. So as a result, the creatinine and the GFR varies according to the blood pressure, because we don't have effective autoregulation anymore of the glomerular blood flow. And then this results in the serum creatinine fluctuating in the absence of clear precipitants. So that's why your serum creatinine is you have to look at more things to actually decide the stages, for example. Now, this person, for example, has the CKD, and this leads to hypertension, because when we sense in the glomerular tubular feedback mechanism, it senses the blood volume, or the amount of blood volume, so like the blood pressure. So if it senses that the blood pressure is too low, it's going to start releasing renin, for example, and this is going to lead to this whole chain reaction where it will release further things like aldosterone and angiotensinogen 2, and so that's where the ACE inhibitors come in. But the thing is, it leads to hypertension, but hypertension is also one of the risk factors, because hypertension can damage the glomeruli, and when it is damaged, because we have a lack of perfusion, the kidney or the all these feedback mechanisms, they sense that there's not enough blood pressure to have effective perfusion of the kidney, so they will increase blood pressure even more. So that's why it can be the primary or secondary to acute kidney injury. So we start getting this kind of feedback, where the one it's like a positive feedback circle here, because as the one gets worse, we are more vulnerable for further acute kidney injuries, and every acute kidney injury just makes the position of the person that already has kidney issues, it makes their position even worse. So that is it for this mind map. And as I said, put any comments, any ideas or any suggestions that you guys have. This is very new for me at the moment, so I am striving to improve. But yes, I look forward to reading your comments and hearing from you guys. So until my next video, I'll map you later.